Good afternoon, everyone. My name's Simon, and I'm a paediatric surgeon and clinical director from Alder Hey Children's Hospital, which is Children's Specialist Trust in the northwest of England. I'd like to introduce Ian, who's a paediatrician from Warrington, Jenny, who's a general manager from Warrington, and Therese, who's director of strategy at Alder Hey. Our ambition is delivery of excellent paediatric care to the children of the northwest of England through a single unified workforce with a unified clinical leadership and governance structure. Yesterday, it was pointed out that 25% of emergency admissions were children and that the UK lagged our European partners in infant and child mortality. Alder Hey is recognised as a national and international leader in children's healthcare, and our outcomes in cardiac and neonatal surgery are demonstrably world-class. So why is there a mismatch between our institutional outcomes and the child mortality figures? We continuously monitor avoidable deaths, and the answer is that children are falling between the gaps between community, primary, secondary and tertiary care. Adding to this is the immediate and increasing challenge in the children's workforce, where big gaps are appearing in both senior and junior emergency on-call rotas. We'd like to illustrate some of the issues we face with a patient story. Amy is a 12-year-old girl who I operated on 3 Saturdays ago at 2 o'clock in the morning. She's got cerebral palsy and chronic respiratory disease. She had a long history of non-compliance with medication, and she was transferred to the intensive care unit at Alder Hey, having had a cardiac arrest at a district general hospital. This was sufficiently severe that she ended up with a significant further brain injury, ongoing worsened chest problems, and I had to remove a piece of dead intestine because the blood supply had been cut off. Amy's now marooned at Alder Hey. She needs drip feeding, and she needs help with her breathing that can only be delivered at the moment at Alder Hey. That's 20 miles from her home, and her family are struggling to cope.
Imagine a healthcare system where children and their families can get appropriate specialist-level care delivered locally. Patient surveys and talking to patients have shown that they want high-quality specialist care, quite rightly. But they want this delivered locally where that's appropriate. As Amy's condition stabilised, her family wanted her to continue her care locally back at Warrington. In theory, I wanted Amy back as well, so she could continue to have local care. Amy and her immediate family, they needed support from the extended family. It's difficult to get that when you're travelling back and forth or staying in hospital accommodation. The siblings, they also need time with their family as well. Unfortunately, there's no processes or a lack of experience with drip feeding older children locally. We're not funded for high dependency assisted long-term ventilation. But using integrated clinical care pathways developed by tertiary and secondary care specialists, delivered by secondary care with both support and advice from tertiary specialists, and backed up by robust clinical governance mechanisms, this could happen. This tackles variation in quality, it improves safety through standardisation and continuous improvement. When Amy is ready to go home, she and her carers will also need support from local community nursing teams, from school health, primary care, social care. After significant illnesses like this, siblings often need help from psychology and mental health. But taking a step back, could this have been avoided? With collaboration of skills and support between tertiary and secondary care across sites, and ultimately primary care and community, and the use of standardised care pathways, this can prevent a proportion of community deteriorations and support in the community. Improved collaboration between multidisciplinary, multi-specialist teams can provide appropriately trained staff that can be located in optimum areas to provide excellence in paediatric partnership and care. I want the best care for my patients that's not hindered by commissioning and contract difficulties due to being two separate entities. Being one integrated paediatric partnership, providing excellent care under a joint board.
Alder Hey is about to move into a new hospital designed with the help of children, which has Europe's largest paediatric critical care floor, which is for all the children of all the northwest of England. But we have a national and local pressure on this scarce resource, particularly in winter where we also have to deliver congenital, cardiac and neonatal surgery. Reducing avoidable admissions will create massive efficiencies.
We are asking for a Vanguard programme to help us with organisational development and project management support, for financial and logic modelling assistance for robust design frameworks, for expertise to help us develop and implement performance frameworks with access to the National Innovation Pool, and for solutions to help support us with commissioning. What we will give back is a fully integrated service that can be replicated with patient engagement throughout. Alder Hey have a significant track record in this already. For example, children sit on consultant interviews. There's a nationally recognised mental health engagement group, and children were instrumental in the redesign and design of their new hospital build that's due to open soon.
This is a meeting of strengths. It's not a takeover. We are two foundation trusts with board approval and willingness to have difficult conversations about activity and sovereignty and gain share and control. And we will be held accountable for our decisions by peers, colleagues and patients. Alder Hey provides services in more than 25 hospitals across the region, and in each of these our clinicians have established trusted relationships. We will prove our model at a manageable scale in a local lab with two organisations where the transition risk is low. We will then step the model up and out through these 25 clinical relationships in region and then nationally through our networks such as the Children's Hospitals Alliance. Our proposition is not about viable smaller hospitals, but about thriving, flourishing, vibrant ones, and about specialist hospitals that are truly specialist. Our proposition is that children and young people receive the care, treatment and respect that they deserve locally from a single expert paediatric workforce. We have already begun our transformation journey and we would very much like you to join us in it.
Thank you very much. Any questions from the team from Alder Hey? Down here. Number 6, please.
Liam Brennan from the Royal College of Anaesthetists. The challenge for delivering, particularly for the sicker end of the spectrum of children's services, is going to be upskilling the workforce in secondary care who may not have the confidence to manage the high dependency and intensive care needs of these children. How are you going to guarantee that?
That's something which we attack from several angles, really. Within Alder Hey, we had the same problem in miniature, which was how are we delivering the more complex children's healthcare interventions outside of critical care. And so for nursing staff in particular, we've already established educational programs that give them the confidence to deliver those services off our critical care floor and let us keep our flow of patients going. What I suspect you're asking about particularly is airway management and in anaesthesia. And we have a model at Alder Hey where we already have anaesthetists who, in Warrington, for example, who come and they spend time at Alder Hey delivering care day in, day out, and then they go back to the District General Hospital. And so they can create a reservoir of expertise that they can use to assure airway management across District Generals.
Question number 10.
Hi, Jackie Cornish, NHS England National Clinical Director for Children. Very much admire Alder Hey, great centre. You've got a lovely hospital you're about to move into. I'm just kind of wondering what's new and what's different about this and why you shouldn't have been doing it anyway. I mean, you say you've got your relationships with 25 DGHs around the place. What actually makes this different when really all the tertiary centres are about good clinical standards with their referring DGHs and communities? Why is this particularly different?
The answer was in my first statement, and the answer is that it's a single unified workforce, so that we're removing the boundaries between different organisations. So, as we've said, we've had relationships with Warrington Hospital for over 40 years. We've got intimate relationship with the clinicians, but we don't have the same supply chains. We don't have the same clinical governance systems. So it takes those things away, and it fits very neatly in with working with things like operational delivery networks.
Sorry, if I just... one issue that we've got at the moment is the payment system, and that's one thing that we're asking the Vanguard about. Current payment policy, it encourages providers to continue care within a hospital rather than kind of spreading that load out. And by changing the payment models, by changing the way that different aspects of care are funded, that will help. We've spoken with preliminary negotiations with the CCG, who are all behind it, but their issue is partly payment. If we do more local care, are we going to get a tertiary banding, tertiary funding, and then bankrupt the CCG, which is certainly what this is not about. So unpicking that banding structure or funding structure, that's one of the real challenges, and that's one of the things from the help from the Vanguard.
Question 24, please.
Hi, I'm Anish Kashu from the Royal College of Pediatrics and Child Health. Picking up from Jackie's point, are you not missing an opportunity here for full vertical integration of the pathway by including out-of-hours pediatric care and general practice pediatric care as well? Because that would be perhaps a more appropriate model to showcase.
Completely agree. And that, I mean, if you're looking from a longer term aspect and an inspirational aspect, that would be ideal, and that would be my delight, to keep children that need care at home, so that they don't even go through the hospital doors, so that they're assessed and cared for by the general practitioner, the primary care teams, the community nursing teams, and then care can be tiered, and it's appropriate care in the appropriate setting, and that's what we'd be aiming for in the long term.
And final question from table number 18, please.
Hi there, I'm Jane Rowland from the RUH in Bath. Firstly, it feels a little bit more like a network-based model of care you're proposing than perhaps a franchise. And I guess the second question I wanted to ask was, knowing that there are nursing and AHP challenges around, particularly around paediatric services, just like to understand a little bit more about how you propose tackling some of that so you can ensure the appropriate level of support is there for the services in the local centres.
Firstly, it's not a network. So it is, as we say, it's a single provider of care. So we're just taking down those boundaries. In terms of the AHP workforce, they were working with local higher education institutes. I'm working from a low base, actually, because I think advanced nurse practitioners haven't been valued by health services, but we have a lot of them at Alder Hey, and we're building that up with higher education institutes.
Thank you. That's the last question. So can I have a big round of applause for the team from Alder Hey, please?